Good morning, everyone. I guess it's my turn now. I'm so happy. Oh my God. Next, it's your turn. So on the slide note, respected all, I start my presentation today on preimplantation genetic testing, PGT. So this is normal fertilization, where you can see that after the sperm and the egg, they meet, the sperm penetrates the egg, there is fertilization, which is denoted by presence of the male and the female gametes over here. I will show you a video of how fertilization takes place in the lab. The single cell divides into two, then into the 4-cell embryo, the 8-cell, and then the 16 to 32 cell morula. And finally differentiates into a blastocyst with fluid in the center, inner cell mass, and the trophectoderm on the border. Once again, this is the embryo which divides into 2-cell, 4-cell, 8-cell, and then progressively to form the morula, the blastocyst, and differentiates into the inner cell body and the trophectoderm on the border. This is a beautiful blastocyst which hatches from this point. And the embryo comes out and sticks to the endometrium. Preimplantation genetic testing is the process of detecting various types of genetic abnormalities in the embryo created in the lab before it is transferred to the uterus of the recipient. These genetic abnormalities include a missing chromosome like Down syndrome, rearrangement of genes, or single gene disorder like sickle cell anemia that can cause birth defects or pregnancy loss. The main goal of PGT is to transfer a healthy embryo that is free from certain types of genetic disorders for a successful pregnancy. The history of PGT dates back to 1968, where the first embryo biopsy was done on rabbit embryos in UK. In PGT was first developed in UK in the mid-1980s. This is the BMJ volume in 1984 in 14 July, which speaks about this test. In 1989, London colleagues reported the first unaffected child born through PGT. As of 2010, more than 23,276 PGS cycles have been reported. The pioneers in these are Werlinski and Cooley. The applications in artificial reproductive technology, the expected advantages. PGT increases the implantation rate, decreases abortion rate, gives rise to less abnormal pregnancies. Single embryo transfer is more possible. It decreases the time to pregnancy and increases the cost effectiveness. The chromosomally abnormal. Several studies have shown that about 50% of human implantation embryos from IVF are chromosomally abnormal. The rate of abnormalities is affected greatly by female age, as we can see. At age 44, we can see the rate of chromosomal abnormalities here as high as 90%. To a great extent, the chromosomally abnormalities are responsible for failure of implantation of these IVF embryos and also responsible for about 70% of miscarriages in early pregnancy. So what is the rationale for this PGS? More aneuploidies in human embryos, that is 7 to 10% aneuploids, low implantation potential, and a high miscarriage rate is the reason why PGS was developed. Aneuploidies can arise in the oocytes, that is the egg, in the embryos. In the oocyte, the factors are age of the oocyte, intrinsic gamete problems, and the prevalence is about 33% at 22 years, but more than 50% over 40 years. Whereas in the embryos, the prevalence is 58% under 30 years and 77% above 39 years. 2/3 of the human cleavage stage embryos, that is the day 2 embryos, 4-cell, are having aneuploidies. The factors are chaotic patterns, abnormal ploidies, chromosome loss, and mitotic non-disjunction. So what is the difference between the two, the PGD and the PGS? And which one should we do? PGD applies when one or both genetic parents carry a gene mutation or a chromosomally abnormal chromosomal rearrangement, and testing is performed to determine whether that specific mutation or an unbalanced complement has been transmitted to the oocyte or the embryo. Whereas PGS is screening. It applies when genetic parents are presumed to be chromosomally normal and their embryos are screened for aneuploidies. The PGT, formerly known as the preimplantation genetic diagnosis, that is PGD, is a genetic analysis performed on embryos during IVF. PGS, preimplantation genetic screening, refers to removing one or more of the cells from an IVF embryo to test for chromosomal normalcy. Having an extra chromosome causes problems like Down syndrome. This can be detected by PGS, that is screening. PGS does not test for a specific disease like cystic fibrosis. That process is referred to as PGD, that is now known as PGT. Now, comparison between the two at a glance, PGD and PGS. PGD is therefore a procedure which is done before the implantation of the embryos to help detect genetic defects and to ensure that these are not passed on to the child. Whereas PGS is a procedure which is done before the implantation of the embryos, where the embryos are generally screened and that they have a normal makeup or not. So PGS is for general screening, PGD is for a single known abnormality. Gender selection is possible in PGS and also in PGD. It is safe in both cases, and harm component is more in PGS than in PGD. The timeline is 1 to 2 days or 3 to 40 days, depends, but PGD only takes 1 day. And desired outcome accuracy is 97 to 99%. That is a bit less in PGS compared to PGD. Legally allowed is yes in some countries, and cost is higher in PGS compared to PGD. So PGD is developed to avoid the transfer of embryos affected by a specific genetic disease that is usually applied for fertile patients. Whereas PGS is for infertile patients, that is those who are going for IVF, not getting pregnant. Infertility cases, PGS is more for them. No preliminary workup is required, and genetic testing method is same for every couple. Whereas in PGD, workup is required for each couple. Now, that is the aim. The aim of PGT is to identify the normal embryos, achieve a genetically normal pregnancy and birth, whereas PGS is to achieve a pregnancy birth. So these are the infertility patients. Indications being advanced maternal age, repeated implantation failure, repeated miscarriages, and severe male factor infertility. It's usually done on day 3. And recently, polar body and blastocyst biopsies are also being used. Whereas PGD, as I already said, is done on the fertile patients, usually on day 3. And these are the methods used. And if the embryos are found to be inconclusive results or undiagnosed, then they are never transferred. But in PGS, they can be transferred, taking a risk. Now, indications for the preimplantation genetic screening. So screening is for young female patients who have had experience of recurrent pregnancy loss, usually defined as 2 or more consecutive miscarriages, young patients who've had experience of repeated IVF failures, and advanced female age more than 35 years. Minor disabilities can be also detected. PGD has occasionally been used to select an embryo for the presence of a particular disease or disability such as deafness, in order that the child would share that characteristic with the parents. So the indications of preimplantation genetic testing, on the other hand, is single gene disorders, structural chromosomal parental anomalies, and other indications. So single gene disorders are the autosomal recessive, X-linked recessive, and the autosomal dominant. The structural chromosomal parental anomalies are the Robertsonian translocation, reciprocal translocations, and others, whereas other indications are mitochondrial pathologies, late onset disorders like Huntington's disease, inherited predisposition to cancer, and HLA genotyping. So PGD is done with couples with a family history of X-linked disorders, couples with chromosomal translocations, carriers of autosomal recessive disease, and carriers of autosomal dominant disease. These people are not infertility cases. Whereas PGS is done for people more with infertility, that is, or recurrent pregnancy losses, women with more than 35 years of age, repeated IVF failure, or severe male factor infertility, and patients undergoing chemotherapy. What are the disease screenable by PGT? Age-related aneuploidies, alpha thalassemia, beta thalassemia, congenital adrenal hyperplasia, Down syndrome, cystic fibrosis, Duchenne's, and you can see the list. Now, preimplantation genetic test and nomenclature has been recently altered. A fourth type has been added, that is the PGT-HLA. The three types which existed till date was the PGT-A, that is for aneuploidies, M, which is for monogenic disorders, including cystic fibrosis, breast cancer genes, or Huntington disease, and SR, which is for the structural rearrangements, the Robertsonian and the other translocation. Whereas the fourth one that has been added is the HLA, PGT-HLA. The aim of this procedure is to establish a pregnancy in which the fetus is HLA compatible with an affected sibling in need for a hematopoietic stem cell transplantation. So the types. So PGT-A, as we already said, is if the embryo consists of an extra chromosome or one less, there is aneuploidy. So this will detect those. Whereas monogenic disorders like hemophilia and the others that we said is checked by this form of PGT. Structural rearrangements include embryos where abnormal size or Robertsonian or the other translocation is detected, and HLA where a compatible HLA a compatible sibling is required for hematopoietic stem cell transmission. What is the indications of PGT-A? A is where there is history of recurrent miscarriage, several failed IVF cycles, severe male factor infertility, previous abnormal baby, age more than 38, and aneuploid embryos at-risk people. Whereas PGT A, what does it aim at? It aims at reducing the miscarriage rates, increasing the pregnancy rates per transfer, less cycles of IVF treatment needed, greater chance of having a healthy child, less wasted transfers, and optional single embryo transfer, where the chromosomally normal embryo is transferred to the uterus. Now, what is the indications of PGT-M? Already I have said some autosomal recessive disorders like breast cancer, beta thal, sickle cell, Fragile X, had autosomal dominant conditions like muscular dystrophy, Charcot-Marie-Tooth disease, X-linked diseases like Fragile X, hemophilia, Duchenne's, and mitochondrial diseases. The most request for PGT-M is in terms of late onset inherited conditions for cancer predisposition syndrome. Cases of these cancers are shown over here, for example, medullary thyroid cancer, tumors in the men tissues, multiple endocrine tissues, breast cancer, ovarian cancer, pancreatic cancer, familial adenomatous polyposis, and so on. Now, what is the indications of PGT-SR, that is structural rearrangement? If you had a child or a pregnancy with a chromosomal rearrangement, or if you have a partner with duplications, deletions, inversions, or translocations, that is reciprocal or Robertsonian. So now HLA. This in 2001, when Walensky and colleagues reported the first successful birth after PGT with HLA matching. The ultimate goal of a PGT and a human leukocyte antigen matching program is the birth of a healthy HLA compatible child for the treatment and cure of a sick sibling. If we do not have a living tissue donor in the family, we may not be able to find one through an unrelated donor. The HLA typing only refers to the HLA typing of the biopsied embryo. HLA is a protein on the or a marker which is present on most of the cells of the body, which makes sure that our immune system knows what belongs to your body and what doesn't. During PGT, we can test HLA to determine if the embryo is identical to a sibling with leukemia. The aim of this procedure is to establish a pregnancy in which the fetus is HLA compatible with an affected sibling in need of a hematopoietic stem cell transplantation. The stem cells for this can be obtained from the cord blood or later from the bone marrow of the HLA compatible selected child. During this, the identification of the compatible embryo is combined with the detection of mutations of underlying immunodeficiencies and hemoglobinopathies. So what is the indications? Acute lymphoid leukemia and acute myeloid leukemia. The commonest ones is beta thal, alpha thalassemia, Fanconi, Viscod-Aldrich syndrome, hyperimmunoglobulin M syndrome, X-linked adrenoleukodystrophy, and Diamond-Blackfan anemia. Indications may slightly vary depending on the study population. These cases are not very common in routine clinical practice, and there are no published guidelines with recommendations on the matter. Now, P is another one which has come in, which is for polygenic risk. The PGT-P estimates an individual risks of developing an adult onset multifactorial condition by looking at the combination of specific genetic variants. But this is different from all other forms of PGT technology, because rather than focusing on a single genetic issue or an extra or a missing genetic material, it is looking for a bigger spectrum of disease with more variation in the hereditary component. It could be helpful if you or your reproductive partner are from the studied population, have a significant family history of the tested genetic conditions without a single genetic cause, and you're expecting many embryos in your IVF cycle. It's important to remember that it's a screening test. There is no guarantee that a specific embryo will or will not be affected by the condition. And there's no right answer, just what you feel is in your family's best interest. Just like the early versions of the electric vehicle, PGT-P is not for everyone. So what are the steps of a PGT? How do they do it? There are 4 steps in PGT-A and 5 steps in M. In the PGT-A, first is a consultation with the physician, followed by the IVF cycle, blastocyst biopsy on day 5, day 6. And then the specimen is taken and sent to the testing lab. And then report comes within the designated time. Frozen embryo transfer cycle is done in the next cycle at the earliest. Whereas in PGT-M, after the physician consultation, the pre-PGT blood sample collection is done from the parents, and then after that IVF cycle and blastocyst biopsy is done, and the whole procedure is repeated. What are the relevant documents? So legalities are very important in this condition. Original copy of the genetic testing, karyotypes, and other specific testing of the index patient, spouse or partner, children or other family members are important. A female reproductive history, male reproductive history, their fertility status, results of the SFA, reports on health problems of both the partners that may affect genetic diagnosis or the outcome of IVF and pregnancy, and a genetic counsel report together with full pedigree and family data. How does it work? So in the first step, IVF treatment is done. The eggs are collected. The embryos are grown in the lab 2 to 3 days until the cells have divided, and the embryo consists of about 8 cells. A trained embryologist removes few of the cells. The chromosomes are examined, how many are there and whether they are normal. 1, 2, or 3 of the embryos without abnormal numbers of chromosomes are transferred to the womb so that they can develop. Any remaining embryos can be frozen for later use. However, embryos that has been biopsied may not be suitable for freezing and use in subsequent treatment cycle. So those embryos that have abnormal chromosomes are allowed to perish or discarded for research. Now, we need to perform a biopsy when and how. The timing of the biopsy can be a polar body biopsy, which is the earliest stage after fertilization, followed by another type, which is a cleavage stage biopsy, that is the day 3 embryo. And the last is a blastocyst biopsy. So there are the 3 stages where we can do the biopsy. So this is the technique. Pre-fertilization, that is where the polar bodies are formed, that they are taking the polar bodies and biopsying them. The polar bodies are not important component of the embryo. So so it doesn't harm the embryo at all. Longer time is available to perform genetic testing without compulsory freezing. The cleavage stage embryo, where 1 or 2 blastomeres are sucked out, longer experience of the embryologist is required, and it's a well-assessed methodology. Whereas the third one is the blastocyst day 5 to day 7 embryo, where 5 to 10 trophectoderm cells, that is the margin cells, are sucked out, and detection and quantification of mosaicism is done. It allows a delayed embryo transfer. There is a frozen cycle. Now, biopsy and sample collection procedure. The first, an opening is created in the zona pellucida, either chemically by thyroid solution or mechanically by a sharp micropipette. And removing of the polar bodies or embryonic cells are done. The third method of creating a hole is by laser, and this is the preferred method, definitely in certain in conditions. It's a guided non-contact laser beam. The sample removal, several methods have been described for the removal depending on the stage and the morphology. For all stages of biopsy, aspiration is done inside the biopsy micropipette is the most commonly used, that is the sucking, as I was telling you. For blastocyst biopsy, aspiration and excision is done with laser. Aspiration or aspiration in combination with mechanical detachment of the trophectoderm cells called flicking, that can also be done. After this sample is collected, the biopsy cells are washed and either fixed on a slide for fish analysis or collected in small tubes for DNA amplification called tubing, which is the most widely method used. First, coming to the polar body biopsies, they are the byproducts of female meiosis, which allows predicting the results and genotype of the maternal contribution to the embryo. In most of the cases, the polar body one, there are two polar bodies based on the size, shape, and position within the perivitelline space, which is just outside the egg. Organization of the biopsy polar bodies can be performed simultaneously or sequentially. In simultaneous biopsy, PB1 and PB2 are removed between 6 hours and 9 hours after insemination. Whereas in sequential biopsy, PB1 is removed within 4 hours and PE is removed, PB2 is removed following fertilization assessment, that is 16 to 18 hours after insemination. Earlier removal of the PB2 is also acceptable. Cryopreserved or warmed oocytes can be biopsied similar to fresh oocytes. So this is the thing showing the polar body biopsy. So this is an embryo, which you can see the evidence just before fertilization. This is the polar body. This is one polar body, and this is the second polar body, and this is the perivitelline space. These are the micropipettes, or everything is under electron microscope. And this is the biopsy needle. This is the laser shot given, punctured. And you can see how the polar body is being sucked out. This is a polar body biopsy. As I said, this is 6 to 9 hours after the pickup. So it's on day 0. Next, we come to cleavage stage biopsy. That is day 3 post-insemination between 6-cell and the pre-compaction stage of the embryo. The exact timing varies according to the timing of the laboratory procedures. Cryopreserved embryos can be biopsied on day 3, similar to fresh embryos. It's recommended to biopsy at least at the 6 or more cell stage on day 3 with an acceptable grade, where the fragmentation is limited to less than 25% according to laboratory policy. Fragmentation is a negative factor within the embryos because more the fragmentation, more the chance of genetic abnormalities. Embryos with a degree of fragmentation between 25 to 50 can be biopsied, taking into account lower chances of implantation and possible issues with genetic diagnosis. Alternatively, these embryos might be cultured to the blastocyst stage for biopsy. The timing of the cleavage stage biopsy, technically it is much more straightforward, good concordance rate despite more specific probes. Disadvantages: chromosomal instability, mosaicism, and no definite conclusion on the basis of one cell. So the number of cells retrieved is less. This is how a cleavage stage biopsy is done. That is the day 3 embryo. You can see the red dot over here. They are putting the laser here, making a hole and sucking one of the blastomeres with the micropipette. These micropipettes are very tiny and they are vibrating at a very, very high speed. This is the holding pipette, which is also holding the embryo by suction. So you can see that minimal injury to the embryo is desirable. The timing of the trough factor biopsy, that is the next one. Sorry. So the timing of the pro-factoderm biopsy, the pro-factoderm biopsy, on the other hand, is when the margin of the embryo is already formed and we are sucking out the cells from that margin. It is less invasive, less embryos are there for biopsies, and mosaicism is very much diluted. What is mosaicism? Mosaicism is where you have embryos with the part of the embryos showing genetic abnormalities and part not. So part of the cells will show mosaicisms are some of the cells are showing part and some of the cells are showing it's not showing the full genetic abnormality, although it is already present. The disadvantage is that it is labor intensive, effect on children insufficiently demonstrated, and need for cryopreservation of embryos. So this is a day 5 blastocyst biopsy, that is the pro-factoderm biopsy, which is different from the other two forms of biopsy. Once again, we put a laser contact beam here, non-contact. And as you can see, we are aspirating the margin cells. Now we have to remember this is a sphere. This is not a 2D, this is a 3D. And inside this thing that you're seeing is a fluid. It's like a ball. And we are sucking only the marginal cells. 5 to 6 cells are taken out, and this doesn't cause any damage to the embryo. This is the inner cell mass where the baby is present. Now, alternative sampling methods. We have seen that PGS and how the embryo component is taken. We also have alternative sampling methods where cell-free DNA analysis is done. Blastocentesis is one, and spent culture media is one. Blastocentesis is when what we showed, the blastocell fluid, it contains cell-free genomic DNA, which can be collected using minimally invasive approach. It's something similar to the NIPT. It can be purified and amplified for gene testing. According to results to date, the efficacy and accuracy of this technique is insufficient and needs further elaboration before being clinically applicable. Whereas the spent culture media, where the culture media in which these embryos are growing, cell-free genomic DNA is taken from them, and they are potentially used for genetic testing. One of the limitations of the technique is current inability to discriminate embryonic DNA from sources of DNA contamination. Further optimization of the methodology is required. Now, this is spent culture medium where the culture fluid is taken and tubing is done. And this is the blastocell fluid, which is aspirated out and put inside. Whole genomic amplification is done, followed by NGS or other methods of detection. Now, the embryology, the process. So the egg and the sperm, they unite to form the embryo. This is the 8-cell stage. One cell is removed on day 3, tested for DNA, and by quick rapid technique, and test results are available. This can be implanted on day 5. In unhealthy conditions, it's used for research. Now, care during this insemination and culture. ICSI is preferable for PGT to minimize the risk of both maternal contamination from residual cumulus cells and paternal contamination from surplus sperm cells attached to the zona pellucida. Careful removal of the cumulus cells and rinsing of the oocytes before ICSI and of the zygotes in case of IVF after fertilization check is critical to avoid residual and maternal contamination in the biopsy samples. The most adequate culture conditions, strategies, and media should be used. If available, time-lapse imaging testing systems should be used also. And following biopsy, oocyte and embryo should be thoroughly rinsed to remove the biopsy medium before culture. To culture the embryos individually, the use of multiple well dishes or droplets in separate dishes is advisable. Now, choosing the embryo, this is time-lapse technology. Embryo quality is very important after grading by a microscope. Major developments have occurred in the time-lapse technology, which allows us to take photographs of the embryo every few minutes. And this data is called the morphokinetic data. That is where we visually see the embryos and we select the embryos to be used for PGT. If something is looking grossly abnormal, we do not select it. So what stage it should be biopsied? It depends on the lab protocol. There is always exceptions. It also depends on the total number of embryos available for biopsy. For example, if the number of embryos are very less, then we cannot choose much as to what stage we should biopsy it. Depends on the patient cohort and doctor-patient philosophy. Next. There should be specific criteria for biopsying the embryos. The minimum grade of the embryo should be a certain level for selection. For poor quality embryos, there is it should be remembered that there is increase in potential for poor quality biopsied cells to increase the aneuploidy rate. So how many cells should you take? 4 to 8 cells is the standard. PGD is recommended up to 10 cells. This is the method in which the tubing is being done. After taking the trophectoderm sample from the biopsy dish and pipetting through the drops in the wash dish, record is done and kept in the small tube. It's very tiny. Centrifuge for DNA amplification and then packed in this box and sent for testing. Now, what is chaotic embryos and self-correction of embryos? Self-correction is a process where mosaic embryo somehow eliminates its aneuploid cell so that it can implant and form a healthy pregnancy. So when there is less number of embryos, then we take these chaotic embryos, that is mosaic embryos, because some of them undergo autocorrection. The facts about these mosaic embryos: unlike embryos with aneuploids, which are more common in women as they get older, mosaic embryos are likely to occur in young patients also. It can be a mixture of normal and abnormal cells in varying proportion. Mosaic embryos are less likely to implant in the uterus. If a mosaic embryo does implant, it's more likely to miscarry. And it's possible that a mosaic embryo to produce a healthy baby, but again, the chances are much less compared to a normal non-mosaic embryo. So the labs that are performing PGT should report the results as normal, abnormal, or mosaic and give the percentage of this mosaic. Should inform the doctors of the sensitivity of the testing platform. And for example, if they can detect mosaic up to 30%, less than 30%, 25%, or 20%. Mosaics are typically reported as euploid, that is less than 20% mosaic, low-level mosaic 20 to 40, high-level mosaic 40 to 80, and aneuploid, which is 80%. Current recommendation of these mosaic embryos are: they should not be used if normal embryos are available. Patient should be informed that the chances of pregnancy is lower and risk of miscarriage is higher. Patients considering the use of these mosaic embryos should have a consultation with the genetic counselor about the mosaic syndromes. And those with mosaic more than 40%, they do poorly and they should be given the lowest priority. Now, the quality control. Before the biopsy procedure, work surfaces, equipment, material should be cleaned properly. During the procedures, protective clothing should be worn. Everything should be sterile. Gloves should be worn at all times. Those latex gloves should not be used. In the genetic laboratory, the report comes like this. And the methods of the DNA analysis from this single cell. After the tubing is done and it goes to the lab for analysis, what are the methods used? Before, fish used to be used, but now there are much more advanced technology, including PCR, microarray, SNP, and NGS. The fish, where they use fluorescent probes, which were specific for a given chromosome that bind to the complementary sequence and can be visualized under the microscope. PCR, which we already know. Generally, PCR-based methods are used for monogenic disorders, whereas fish is used for X-linked diseases. These techniques need to be adapted to be performed on blastomeres. Finally, after the replacement of the embryo, surplus good quality unaffected embryos can be cryopreserved and transferred to a next cycle. The main problem of the use of fish is the elevated risk rates of mosaicism. So fish is not preferred. The main problem is, as we told you, it's considered to have an error rate between 5 to 10%. So these are the advantages of fish. It does not require DNA amplification. It's not able to easily test for all 23 chromosomes, however. Despite its promise of improved clinical outcome, the randomized trials performed over the past 10 years have found that fish-based PGS does not improve the live birth rate. PCR, on the other hand, is a highly sensitive and specific technology. The higher number of cells that is needed, the cycles that is needed, the limited number of template makes single cell PCR very sensitive to contamination. Now, another problems which is specific to single cell PC is the allele dropout, that is the ADO phenomena. It compromises the reliability of the PGT. qPCR, quantitative PCR, is very effective. The highlighting advantage is that it can be completed in just 4 hours. This is the advantages and disadvantages of microarray based comparative genomic hybridization, which is the next one. Single nucleotide polymorphism. The advantages of CGS, which is very, very commonly used, is that they are able to complete the results within 12 to 15 hours, so we can do fresh transfers. Disadvantage, it cannot detect polyploidies. And single nucleotide polymorphism, they are a single nucleotides change in the genomic DNA. Advantages that it can identify triploidies, uniparental disomies. It's costly, however. It takes 2 to 3 days. And the latest technology is the NGS. It is a high output method, which is used to determine a portion of the nucleotide sequence of the individual genome. NGS detected 6 embryos with unbalanced translocations, one of which were not identified by the SNP array. So it's quite sensitive. Now, coming back to the embryo, what is the side effect to the embryo? All these procedures that we do, does it damage the embryo? One of the risks is it can. Another risk is cryopreservation after doing the biopsy, if it's stored back to the frozen state and later thawed for the embryo. About 20% of these thawed embryos in the PGs do not survive. There has been a study indicating a biopsied embryo has a less rate of surviving cryopreservation. So PROS, preimplantation genetic testing, the pros. Embryo selection is possible, so embryos cannot be implanted, but which cannot be implanted are not transferred. It avoids the transfer of embryos that causes pregnancy loss or birth of children with various syndromes and reduces financial burden. Whereas the disadvantages, it is an invasive procedure. It's a difficult decision for moral and emotional reasons. PGT doesn't detect all genetic conditions, syndromes, autism, developmental problems, and does not guarantee the health of the embryo, its implantation, clinical pregnancy, or its survival. Ethical issues are there, of course. And policy and legality. In Bahrain, the Ministry of Health and Family Welfare regulates the concept under IVF and HRA laws. The act was further revised after 1994 and necessary amendments were made on the official website of the Bahrain government dedicated for the cause. Now, the problems in the past, the IVF and PGS for aneuploidies has been used in some clinics in the US since the mid-90s. Studies show that performing embryo biopsy on day 3 and performing the genetic fish is not as good as doing the current techniques. So improvisations has been done, as we already said, the 4 methods, and trophectoderm biopsy, switching from day 3 embryo biopsy. Uterine receptivity issues should be remembered, and which has not, however, been very carefully studied. And conclusion, the potential capabilities and efficiency of the PGT have dramatically increased in recent years due to largely improvements in the ability to accurately test the embryos, defining the exact benefit conferred by PGS and determine exactly which patient population should be best served by PGS, however, is currently controversial. PGS is not for everybody. The various pitfalls like false positives, false negatives, developmental potential of the biopsied embryo and mosaicism, which may affect the pregnancy outcome. Regardless of the improvements, patient must be carefully counseled about the error rates inherent in all PGS technologies as well as outcome reported to date. Patient must be given accurate information with which to make their treatment decision, taking into account their age, ovarian reserve, indications, and methods to be employed. Once the patient is pregnant, antenatal testing with CVS and/or amnion must be discussed, and a strong recommendation for antenatal testing should be included in all PGT consent forms. So remember, PGT must be followed by an NIPT or an amnio-CVS. Alternative treatment strategies such as using donor gametes should also be discussed where it is relevant. So just to conclude, when the world says give up and hope says try one more time, what is at the end of it? I know if I failed, I wouldn't regret, but I knew the one thing I might regret, and that is not trying. Thank you.